Thank you so much, Mr. Ramsay, for spending some time with me. So, as you know, I work in clinical hypnotherapy and I'm also a coach. So I mainly work with women around fertility, whereas you work in the medical side, but you also have a real interest in the social and the psychology that affects male fertility. So, Jonathan, tell me, what do you do with your clients?
Well, I think the first thing, and thank you for the introduction, Andrea, the first thing is to see them together whenever possible, because if ever there was a case for both the parties being involved, this must be it. And I think the next watchword really is to listen to the whole story, because it's about a man and a woman, and with any luck then a baby. But how we get there is going to involve all of them and how they feel about each other.
We kind of work in the same way, but in a completely different way. So you work with men and the medical side, but also the psychological and emotional side, which I feel as a coach and clinical hypnotherapist is super, super important, because we both know fertility is not just about the medical, is it?
Absolutely not, because it is almost a parallel universe, fertility, where success, once one gets to a fertility unit, success is measured at under 50% when we're talking about having babies. Not, of course, when we're talking about pregnancies, that's much easier, not when we're talking about the number of embryos. But if we're talking about the real object of this, which is having a baby, then success for most people may be somewhere between 30 and 40%. So we start off in a parallel universe. We start off in a place where modern people don't operate. We don't buy things, expensive things, that have a 30, 40% chance of working, particularly with no insurance policy. So we're already, I think, on shaky psychological ground. And so I think one has to be extremely careful to manage and help couples and to stop them falling into the trap of believing that at worst the outcome of what they're going to do is binary.
Because it's not just about numbers, is it? I mean, that's ultimately, there's a lot more involved than that, and sometimes people can get really hung up on the numbers, and the images that we see in the media often don't help, do they, with people believing that the fertility completely drops off at a certain age. And this creates a huge amount of stress, doesn't it? And that doesn't help the whole process.
Absolutely. And we know we can measure more accurately the effect of stress in women because of their hormone levels. There's more to measure. But it would be odd if the same things weren't happening to extremely stressed men. And of course, the stress for a man, it's not just that he can't start a family, but it may be that he thinks it's his fault. And there doesn't seem to be anything that he can do to mitigate this. And of course, in psychological terms, as you must find, the helpless state is the most psychologically damaging. So once we've got into a helpless state, the sleep pattern goes, in men often the libido drops, and the whole situation becomes really unpleasant, when actually, if we manage it properly, then the approach and the run-up to having a fertility intervention should be a happy time, not an utterly miserable time. But it has to be managed. Expectations have to be managed.
Exactly. And we both know that sleep and stress negatively impact fertility. So it's really, really important to manage emotions, manage the psychological side. And of course, there's a huge amount of guilt associated with, you know, my mum wants a grandchild, or my wife is desperate for a baby and I can't give it to her. So all of that is kind of swirling round, and that doesn't help. I mean, I like to think of fertility as a bit like that game Jenga, where they're all different bits that have to sit together, and if you pull one out, the whole thing can collapse. And we need to work, in my opinion, with clients in a holistic way.
No, absolutely. And you make the very real point about the anxiety and the worry impacting upon the couple, also the extended family. The potential grandmother may be very helpful if she's recruited, or could, if she's not recruited, actually exacerbate this. Then we've got the friends, the wider circle. Yeah. And suddenly, I don't know the number of times you've heard this, but a lady will say, all my friends are having babies. They're texting me, they're saying the first time they tried, they were pregnant. Of course, you and I know that isn't true, because people don't text and say, I've been trying for ages and nothing's happened. So they only hear about the successful ones. And then the consequence is that the social circle might get smaller, because it's too painful to see the friend from school who's 8 months pregnant and radiant. And so there's a terrible danger of isolation from friends and indeed family, particularly when the family don't know.
Yes, this is a big problem that I find with my clients. It's shutting themselves off from their social circle and feeling really, really bad when they hear that somebody's having a baby, and then feeling guilty because they feel bad.
Exactly.
Like they're a bad person. And not knowing what to say. And then actually their friends often start to draw away because they don't know how to deal with the fact that they're all having babies and then meeting together for play dates and things. And then their friend is kind of left out. And this isolation, it's so, so hard. And it makes it feel, for many of my clients, that their life is being taken away.
Yes.
Not just their potential to become a parent, but actually their life, because it suddenly comes like everything revolves around trying to get pregnant.
Exactly. And of course, because unlike any other aspect of medicine, the outcome here, if you like, the cure, is a baby. And the only alternative to that is no baby. So there is nothing between misery and joy. And if you put that into the context of any other medical situation, it's very seldom the case that you have a symptom and you go and see a specialist and he says, very good, we can cure this, or nothing in between, or I'm terribly sorry, you're going to die. This doesn't happen in medicine. And I think we should get used to the notion as doctors that this is a very different thing. Joy, misery, baby, no misery. And we can't really ameliorate that, because there's no such thing really as getting halfway there.
No.
Because although you can, as the point you were making, you can count the numbers and try and take small solace from the number of embryos, then that's not really the point. And we often miss the point entirely by rather crass remarks when a lady is pregnant but miscarries, by saying, oh, well, you almost made it. That is just awful. But the number of times casually doctors and others will throw that away, particularly as we now know that there may be identifiable causes for recurrent pregnancy loss, and we can actually investigate this and may well be able to mitigate against it.
Now, one of the things that I notice is that generally there is more support for women, and women do tend to find it easier to talk to each other, generally. Not always, but generally women do find it easier to come together in communities and talk and share stuff. But there is relatively little support for men, which must be incredibly difficult, because there's also something very emasculating about having to tell your friends that you have a fertility issue, and potentially it is to do with you if you are a man. So I think that lays an extra layer of pressure, particularly for men. And lots of my clients will ask, what can we do? You know, at what point do we need to start potentially looking a little bit further at the male fertility? Because the women often feel, I don't want to suggest it could be to do with him because I'm not sure how he's going to take it. So what would you say to this?
So, of course, one of the reasons that this happens is because until very recently, there was only one diagnostic tool for men in the kit, and that was a semen analysis. Now, of course, we all know that there is huge biological variation.
Yeah.
Day to day, week to week, depending upon how you were 3 months ago, how you produce the specimen, getting in a terrible state when you do. And we also know that it is a subjective test. This doesn't go into a machine, so it is dependent upon a human observer. So there's another source of variation. And so men being men, they love numbers. So as soon as they see that their sperm density is 1 million under the line, they're upset. They begin to feel a bit inadequate. As soon as they get a motility percentage, which is a bit under the line, and of course the worst of all of these numbers is the wretched morphology. Now, if anything was subjective, it's morphology. And I know that men can have 1% morphology, and they have natural conceptions. So this doesn't have the same importance to a clinician as it is inevitably interpreted to have by the owner of that semen analysis. So we get off onto the wrong footing often before we've even begun. Because if this poor chap had had a semen analysis, 6 weeks later, or even 6 days later, it might have been very different. And once again, it's binary. If the numbers are normal, I'm fine. Yeah. I walk tall out of the clinic saying, I'll never have to do that again, there's nothing wrong with me, which of course may not be a correct assumption, just because the semen analysis is normal. But if any of those numbers are under the line, we are cast down and deflated. So my answer to your question is that it has to be properly interpreted. It has to be looked at in the context of the couple, her age, how long have they been trying, what are his habits, what's his lifestyle, I vividly remember a young man coming into this consulting room, and he was tall and fit and very strong. Now, and she was maybe in her mid-20s. So I'm immediately thinking, what's all this about? And he did look bristlingly strong.
Oh.
So of course, the first question is not, have you ever used steroids or proteins with steroids, but are you still? Because the psychology of that is that one is accepting. Because of course, if you hammer the bloke and start, then he feels guilty. It's all my fault because, they said in the gym this was all right, and they said there was a rescue, and they said they did. So one's just got to take life as we find it. People use stuff. Lots of it. Lots of them. So we just got to be non-judgmental about this, but one can often improve that semen analysis by altering lifestyle and habits very easily.
Yes, and you've touched on a couple of things that are really important to me. I mean, looking as a holistic therapist, looking at the lifestyle and the behaviours is really, really important. And what sometimes I find concerning is that couples may see IVF as a silver bullet, and they just go, they've been trying for a year, it's not worked, right, IVF. And they don't think about looking at their lifestyle, looking about what's going on emotionally between them, looking at their sexual behaviour, as in actually how often are they actually having sex. So there's all sorts of things that people just don't kind of take into account. What are they eating? What type of exercise are they doing? And are they smoking and drinking? And all these things are really, really important. But people tend to think, oh, I'll have IVF and that'll sort it.
Yes, of course, and that is part of, well, it's part of the way in which fertility clinics are advertised. In fact, of course, the whole ethos, which is a cycle of IVF or ICSI being called a treatment, well, it's not really a treatment. So again, we're in a parallel universe. It may, if we are fortunate, be a solution, but it's not really, medically speaking, a treatment. Whereas, if we can treat the man and the woman to improve the fertility, well, then that is a treatment. And we may indeed get a result before the helter-skelter rush to the fertility unit. Because the fertility unit, of course, it's interested in fertility in terms of outcomes, in terms of births, but it's not really interested in the individual's fertility.
No.
It's this is a quite a complicated area of commercial description.
And what I often find is that at this point, sexual problems start coming in because of the stress. So the woman starts really tuning into her cycles and getting those ovulation kits that goes, right, it's time now. And then the men feel under massive pressure to perform. And it no longer becomes about connecting, enjoying each other, being relaxed. Everything is about the outcome. And then men find often that they really don't want to connect with their partners. They are losing the libido. And of course, that's the last thing that you want when you're trying for a baby. So all of these things I think are really, really important. But obviously there are cases where there is some type of intervention made. And I know that you've got certain techniques that I'd love to hear some about that men can...
Well, of course, to reiterate that point, men and women's biology is rather different.
Yeah.
Because that business of wanting a baby, needing a baby, that biological need, it's like a switch. So the contraceptives were in full use until Monday, but on Tuesday of the next week, we need to be pregnant next week.
Yeah.
And this is a bit of a shock to many men who were just sort of trundling along. And if then he has the semen analysis and any of those parameters are a bit dodgy, then of course the need to perform instantly is made worse, because what he's actually thinking is, oh, but my morphology is only 2%, this isn't going to work.
Yeah.
I failed before I've begun. So that is, we come back to taking the meaning of that analysis, trying to understand it, being reassuring. Of course, not falsely reassuring, but pointing out that this is not a bank statement. 25 million today does not mean 25 million yesterday or tomorrow. Something could happen. Something might have happened. And if that indeed, if you were reading, a financial statement, you wouldn't think that there could be such changes. You'd think if you hadn't got anything, you hadn't got anything. But that, of course, isn't true with fertility.
No, and what I really like about your approach is that you give power and information to the clients rather than just telling them, right, these are the numbers and that's it.
But of course, as you say, these are the numbers. We haven't achieved, our life's ambition, a baby for 18 months, maybe a year, maybe 2 years. Then it is entirely natural that you would go to the place that produces babies. Because undeniably, the fertility units do, and we mustn't underestimate what they have done.
Oh, yes.
You know, I mean, crikey, worldwide we're talking about every year, from where we can get the data, which is not, of course, complete, but we're probably talking about 500,000 live births a year from fertility interventions. So we mustn't knock them too much. It's just that step between I've got an abnormal semen analysis, even if it's only slightly abnormal, and therefore the inevitable consequence is IVF. That is the step which may have pernicious consequences psychologically and everything else. But of course, against that, we have to say that across the board, in decent fertility units across our country, across the board, 30%, maybe higher, are achieving that ambition. So it's only the remaining 60 or 70%, and some of those are going to be picked up on the second and third cycle. So in fact, of course, they are, on one level, doing a good job. So it's very easy for you and I, who see those who haven't succeeded and are miserable, to give a rather gloomy view. But I have to say, at some point, whenever we're having a chat with whoever it is, you know, some of my best friends are reproductive gynecologists.
Yeah, I mean, there are lots of babies that would not be around if it was not for IVF. And there is definitely a place for it. It's just that it shouldn't necessarily be the first port of call.
It's how we get there. It's the journey to it.
Yes, and when it is the right time, then it is the right time, but it's considering that journey. So at what point should a couple consider investigating the sperm quality a bit further?
Sure. So certainly if we've had 2 or preferably 3 abnormal results, and we've talked about all those lifestyle issues, then we certainly ought to be looking harder at this, because even if we can't alter it, and we usually can, even if we can't alter it, then the traditional medical approach to making a diagnosis is very helpful, you know, because otherwise we're in a situation of, I've got a low sperm count, we haven't had a baby, sort of, so what? So that's just it, with no discussion about how this might have happened. So I think that is the first thing. Let us apply diagnostic criteria, as in the rest of medicine, to this situation. Whether we can improve it or not, at least we can understand it. Now, of course, the other question is, are you normal? Is a man normally fertile with a normal semen analysis, apparently normal semen analysis? Well, again, one's got to look at the story, because if this is an apparently normal semen analysis and there are a high number of progressively motile sperm, and we've established that they are being delivered to the egg when they should be, and if this couple are in their early 30s, late 20s, of course there's something the matter here. Yeah? Now, it could be that the sperm, although it is numerous and looks okay, it could be that its DNA quality isn't okay. Could be. But it could also be that we are looking at an egg issue or possibly an endometrial issue. So you've got to think, is this unexplained infertility? Because if it's unexplained infertility, we need to explain that. And usually, in my experience, normal sperm count, young woman, not getting pregnant, usually we can. There has to be a reason for that.
It's a bit like a jigsaw, isn't it? And each of the tests is like another piece going into the jigsaw that allows you to begin to see a clearer picture of what is exactly going on. And you know, anybody that does jigsaws knows that you need to have a certain amount there before you can actually work out what the picture is.
Precisely. Precisely so.
So in the case of, say, recurrent miscarriages, many of my clients, the female clients, automatically feel that it obviously must be their fault because they have initially got pregnant.
So, well, of course, 2 out of 3 of the possible causes are female, and it used to be thought that frankly it was all female. So 2 out of the 3 possible causes relate to the receptivity of the endometrium, the lining of the uterus, and gynecologists are generally quite good at that because clearly this is gynecology.
Yeah.
It's about the womb. And then some of those recurrent miscarriages, particularly when they're later in pregnancy, may well be related to underlying egg quality, irrespective really of the number of eggs that might remain. But then the third issue, which is one that is only relatively recently being recognized, is the DNA quality of the sperm. So what is the payload? What is the genetic payload? I mean, it is extraordinary, isn't it, that the baby, having a baby, that baby, when it comes to it, was created from a little DNA package in the egg, the size of a pinhead, really tightly packed to have 50% of the information, and then the same, a tight package of DNA in the sperm head. And those two little packages of DNA are going to create one of us. Now, if that DNA is becoming unpacked, unraveled, fragmented, that's all the DNA fragmentation test is. If it's becoming unraveled, then it is unable, like a ticker tape, to give the instruction for the creation of an embryo, a blastocyst, an embryo which sticks, and eventually a human being. So it's not really surprising that 50% of the problem could be male, seeing as that's 50% of the genetic package.
And following on from there, so is sperm quality a large factor in eggs not fertilizing in the IVF labs, or not so much?
I must be very careful not to stray onto gynecological territory. But the fertilization issue is, I think, a bit more egg than sperm. The creation of the 5-day embryo, the blastocyst, may be given a certain number of fertilized eggs. That may be more sperm than egg. So the beginning of this, more egg than sperm, the end of this to 5 days, more sperm than egg.
That's fascinating. And what causes sperm not to mature? That's a question I'm often asked by clients who have been told that their partner's sperm isn't maturing properly.
Well, of course, that might be a way of describing what I've just described.
Okay.
Yeah, it may be a shorthand for that. But the creation of immature sperm, or the release of immature sperm, does have a basis in the nature of the production lines in the testicle, which is an extremely complicated issue, where that production line ceases before the sperm is mature. Now, in those cases, of course, those sperm do not appear in the ejaculate.
Okay.
Okay, so I think the answer to your question about the maturity is probably a way of talking about DNA quality of sperm, talking about the DNA fragmentation.
And what about when men have been diagnosed with azoospermia?
Well, once again, diagnosis is absolutely key. Crikey, the diagnosis of azoospermia, or the consultation at which that information is given, is handled, in my opinion and experience, extremely badly.
Okay.
Because I think that if we take doctors in general, the number of men they will have met throughout their training and throughout their practice with azoospermia, no sperm, is very small. And I reflect that people like me, who have taught many medical students, have probably not done a very good job in pointing out that telling a man that there are no sperm is almost equivalent to a cancer diagnosis. It is devastating because it is, again, it's this business of binary. None. And the bloke will say, what, none? And the doctor looks at the report and says, well, none, I'm very sorry. You know, and that's it. Usually at that point, because there haven't been any other investigations, it's just this one investigation that hits them like a poleaxe. And so we have to make a diagnosis. So if I'm seeing a chap who's just had this, the first thing to do is to sympathise, because this is awful.
Yeah.
And then to get the diagnosis and to distinguish between those who may be obstructed, those who may actually not really be azoospermic. They may actually be making a few sperm, and we might be able to encourage that, not usually to the point at which they can conceive naturally, but we may be able to get from a seemingly impossible place to a possible place.
Okay.
And then, of course, there will be some men who have taken anabolic steroids. And you know, they stop that, and in 4 months they'll have sperm. And then we got those who may have a genetic cause. It's a relatively small number. And those who genuinely cannot make sperm. But as you can see, there are many possibilities here, including the possibility that that test was too negative, that perhaps it wasn't carried out exhaustively enough to find a few sperm. So there's a long way we can go to make the diagnosis, to understand the diagnosis. And if it really, really is the case that the testicles are incapable of making sperm, then we must help to handle that too. But
Okay,
this
so
is a journey.
Yes, so I'm hearing that it's definitely not a case if somebody gets a diagnosis that they should feel that's it.
Certainly
That they
not.
actually do need to come
That-
for
yeah.
more explorative
Absolutely.
tests and find out
Yeah.
why.
They will feel that's it.
Of course.
They will, and they may go off and hide.
Yeah.
But we can go further.
But that's great that there is that facility that things can be investigated further, because you know several of the men that I've spoken to were not aware of that, so they just thought, well, that's it.
Sure. I mean, to put this into make a rather fatuous analogy, you know, you or I wake up tomorrow morning and we can't move our legs, so therefore we can't walk. Well, the consequence isn't, well, bad luck, get a wheelchair. You know, it's let's just see why and how and what we might be able to do.
Yeah. So what type of interventions can you do, or do you do in the clinic?
Oh, so there are, first of all, we must make sure that this hasn't happened for an extraneous reason. Yeah? The steroids is the obvious thing, and testosterone supplementation. There are other drugs that can do this. And then we have to think to ourselves, has something happened to this bloke? Yeah? Has he had an infection that might have involved both of his testicles? And therefore there might be an obstruction. Yeah? Could there be an obstruction at the level of the prostate? Yeah? Could this be hormonal? Is there a genetic cause? So there are many iterations which allow improvement. And of course, if there's an obstruction, then a sperm retrieval procedure will work. There'll be good sperm hidden in the testicles. And just occasionally one might be able to reconstruct it and allow sperm to come back to the ejaculate.
Brilliant. And also I'm often asked, do sperm, we know that eggs, when taken out of the body, get stressed. Does sperm?
Oh yes, it goes off. It's only got a certain amount of power with it. Yeah? It's only got a certain amount of metabolic reserve. So you do have to be careful with them, particularly outside the body. You don't want to leave them around for too long. And if you're going to freeze them, you want to do this in a scientific, careful manner. Prepare them first. So yes, they don't like hanging around.
And are you aware that if men are very stressed, like if they've got a really high stress job and they're obviously under the stress because there's fertility issues, can that actually affect the quality of the sperm?
Well, you see, to study that and prove it is almost impossible. I would say impossible. And in the whole of fertility, when people quite rightfully want to have regard for evidence, it's really difficult to get evidence here. Like almost impossible. Because what is the outcome? So if you were looking at a group of stressed men, first of all, how do you measure their stress to put them into the study? How do you randomize them to see whether there is a difference? So you're sitting in the clinic and you say to one chap or every other bloke, you say, look, you just go on being stressed. It's fine. We don't know whether it affects your fertility. And his partner's sitting there and saying, well, you know, it could do. So we're not having that. So you can't run a prospective trial in which you don't do anything. It's really, really difficult because this involves two people and this very important outcome. So to get that evidence, you'd have to have the randomized prospective trial in which one arm you don't do anything, the other arm you do something. And then you've got to run it for 9, 10 months, a year, and then you've got to follow up the outcomes. Not just did they get pregnant, but was there a live birth? So this is like almost impossible. So as soon as people start talking about evidence, my infertility, I sort of glaze over a bit. Now there's data. Data is different.
Yeah.
Data is stuff. And on stuff, you and I develop opinions, and then we have those opinions, and we've got to be very careful with those opinions. We have to say to the patients, there's what people know, there's what they think they know, and then there's what I think.
Yeah.
I think. But one's got to be very careful not to confuse I think with evidence.
So, but it's probably a fairly good measure to reduce stress in case.
Oh, absolutely. That is what I think.
Yeah.
Because it can't be right to be turning your nights into days.
No.
Be sitting on the computer at midnight.
No.
You know, to be getting up to go to the trading floor or a long commute to a hard manual day's work, you know, getting up at 5:30 in the morning. You know, so people are pinching their sleeping at both ends.
And they're also pinching their life. I mean, people are working really long hours now and spending a lot of time sitting down rather than actually moving, and that impacts their health, and all of that has to have some ramifications on fertility.
Yeah, I'm sure you're right.
Thank you so much, Jonathan. That's been absolutely fascinating. I love hearing about things from your side of the fence, as it were. Real insights, so I appreciate you spending the time with me.
And the thanks, of course, is entirely mutual and reciprocated, because I think that the psychology of our patient's predicament is something that is overlooked almost all the time. So thank you.
You're welcome.